and there's currently no way to know that an implanted stent is working properly besides expensive, complex, and invasive procedures like a catheter angiography, for example. So we have created this technology to specifically aid these patients in the first instance.
You mentioned, you are using a microwave-based technology, so which is non-invasive.
It's similar to an ultrasound. We have two antennas, and our algorithms process this in seconds. So the whole process can last at most 5 minutes.
Okay, hello Oriol. Thanks for joining us in Scouted by GreyB. I'm very happy and excited to see you. How are you doing today?
Thank you very much for having me. It's rainy today in Barcelona, which is not usual, but it's a good day. Thank you.
Nice. I just wanted to know, is what's going on? Any exciting thing happened lately that you'd like to share with me?
Yeah, so we just finished our first in-human trial in 11 patients. We have the data already analyzed. It's really promising. We have been accepted to present it at the EuroPCR, which is the largest congress in interventional cardiology in the world. So this is really interesting for us to be able to share this with the medical community. With this in parallel, we have our Series A round ongoing, just started. So lots of interest, really good experience, but let's see how we close this.
This is amazing news. Congratulations on it. Can you tell me, like in simple terms, what is Nimble Diagnostic doing and what is the innovation that you brought to the market?
Sure. So Nimble Diagnostics was born with the idea of bridging a gap between current diagnostic tools like MRA, CTA, ultrasound that we all know, and it's implanted everywhere, with the patient of the future, and which is currently more the patient of today, which is that these techniques don't work well with patients that have metallic implants or medical devices implanted in the body. And usually they have trouble getting good diagnosis on that area or having good diagnosis on specifically issues with this implant. So we fitted Nimble to bridge this gap and create a technology based on microwaves to create the first in class, the first technology able to monitor specifically metallic implants in the body. And given that our background is in cardiology, our first indication, and we're laser focused now on diagnosing and helping diagnose cardiovascular stents, which are these small metallic mesh tubes that are used to reopen blocked arteries and restore the correct flow of blood to the tissue. And they are mainly used to treat heart attacks, although they have many other applications in cerebrovascular, peripheral disease, renal, pulmonary, you name it. And they can become blocked or damaged over time. And there's currently no way to know that an implanted stent is working properly besides expensive, complex, and invasive procedures like a catheter angiography, for example. So we have created this technology to specifically aid these patients in the first instance.
Okay, and I think what you said is it's impossible to detect such kind of complications early on, and once you detect, it's almost always too late because the complications are already there. So basically, but then how does Nimble Diagnostic is able to early detect this using, you mentioned, you are using a microwave based technology, so which is non-invasive. So can you tell me, how the technology is working behind this?
Yes. So the device itself, in its current iteration, of course, it's similar to an ultrasound, but instead of having one transducer, we have two antennas that go on top of the skin, just near the stent location. If it's a cardiac stent, of course, it goes on the chest. If it's a leg stent, you put it on the leg, but just near the stent location. Our system indicates if the antennas are well positioned to have a good signal. It's not that we need something super complicated. It's just that the signal is good enough. And then you click play. One of the antennas sends a microwave signal that bounces off the stent, and our algorithms process this in seconds. So the whole process can last at most 5 minutes. It's completely non-invasive, painless. It can be done in any clinical setting. It's especially designed to be used in the outpatient setting, so you don't need to be in a hospital. It can be done in primary care or private clinics, whatever it is. And most importantly, we do not generate an image that an expert needs to interpret, like with ultrasounds or CTAs or MRIs. We just provide the clinically relevant information that it's useful for clinicians to manage this patient better. So if the stent is blocked, we can quantify this blockage. It is the first time that we can quantify this sort of blockages non-invasively. And if there is a fracture, for example, what type of fracture? It's a complete fracture or it's just a nick on the stent, whatever it is. We give this information as it is, not image, no interpretation, automatic, everything super fast, so clinicians can act on it anywhere super fast. So the idea is that if you can, for the first time, monitor a patient over time, you can identify problems early on before symptoms appear, as you were saying, and then decide on the best treatment at the best time. Instead of reacting to a problem, we can be proactive in its treatment.
You mentioned that you can also monitor fractures and structural failure in stunts. So, and I understand position shifts and maybe some kind of misalignment can be easily detected. But see, these fractures are very rare. And but basically, how is Nimble's technology able to detect such small? I'm imagining these might be very small and minute changes to structure. So how is basically Nimble Tech is able to detect those as well?
Yeah, so the whole premise is that we're looking very small things in a very small implant inside the heart, which is moving constantly, which has lungs on top, has ribs on top, has tissue, has muscle. So we have a lot of algorithms to process the signal and clean the signal up. But what we have is algorithms that have been tested first in silico with simulations, then were validated in vitro in open air stents, then were validated in vivo in mice, and then in pigs. So we have had a lot of refinement over these models, and we have an algorithm that can process this and correlate really well with this type of problems. In this case, microwaves it's an electromagnetic signature. So any change on how this electromagnetic signal is traveled across the body or across the device itself. So, for example, a fracture, you can see like how a microwave can travel through the stent. Then you find that there's tissue and then again stent. So these differences are quite large. In fact, when we analyze the electrical properties of the tissues and the metal, etc., and we can detect that and process it quite not easily because it's not easy what we do. But at this point, we have this very pinpointed.
Even these like are already very minute things that we are monitoring, and the fractures are even smaller than them. So what I understand is basically we have a proprietary technology which is able to monitor all these basically it's stunts or metallic parts in body, and it's able to do it very accurately and super fast. And so the outcome is basically we have a device that can be placed in any clinical or diagnostic center, and then patients can simply walk in, get tested or get checked in just 5 minutes.
Exactly.
And then leave.
So this just to mention, of course, this technology has been patented already. We have one patent granted and second patent submitted, third patent in drafting stages. The algorithms have been protected, the trademarks, industrial design, as much as we can, this has been protected. And the idea or what we visualize now to use this as a first iteration, as I said, because we're laser focused on cardiac stents, we see two main benefits or three main benefits with the technology. The first one is that during stent implantation, the same time that a patient has a heart attack, then it gets required to implant a stent, the first in-line treatment. At the moment of implantation, some problems can happen. It's not typical, but it can happen because you need to inflate the stent inside the artery, a lot of pressure, around 10 atmospheres of pressure. So you can overinflate it, you can underinflate it, you can inflate it correctly, but then the stent can collapse, it can break. Some things can happen during implantation. And usually if these problems arise, symptoms appear during the first week. It can be on the first hours, but it can be up to 3 to 5 days. So then the patient starts feeling symptoms again and has to come back and has a new procedure done, etc. So with our technology, we can ensure that the procedure has gone well, that the stent is well implanted, everything's fine, and you can discharge the patient safely and faster home. That's the first thing. Secondly, because in some hospitals, it's not typical in Europe, but for example, in Germany, it is. But in the US or South America or Asia, where many hospitals are private, these patients have this invasive procedure, catheter angiography, which is the only thing that clinicians have to look into a stent, which is put a catheter through usually the radial artery in the arm or the leg and get to the heart, inside the heart, and look inside the artery, which of course complex, expensive, invasive, etc. They have this procedure done at 6 months after implantation just to know that everything's fine, even if the patient has no symptoms. So we could substitute these specific angiographies with our technology because we can give the same information, but completely non-invasive, much faster, and much more cost-effective for the system. And the main application, of course, is follow-up over time for these patients. And this can have two sides. So first is asymptomatic patients. There are subpopulations that are more at risk of having problems if you have diabetes, for example. If the stent is positioned in a bifurcation, which is a complex lesion, or if the stent is positioned in the left main artery, which is one of the largest arteries supplying blood to the heart. So if you have some of these high-risk patients, having this follow-up over time to identify problems before symptoms appear can be really beneficial to avoid a second heart attack, stroke, sudden death that can be avoided because if we know that there's a problem in the implant, we can treat it before this is significant. That's one of the major applications. And the second one is those patients that already come to the clinic with symptoms, but the symptoms are usually quite general. So you have to imagine a patient that comes and say, hey, maybe I feel a little bit more tired than usual, or I have a little bit of chest pain, or I get dizzy sometimes. But if this patient is of advanced age, has chronic kidney disease, or have respiratory insufficiency, diabetes, whatever it is, being a little bit more tired or having chest pain, but it's not localized, it's not the typical symptoms, it's what we call atypical angina. It's difficult to know if that can come from the failing of the stent or any other problem or comorbidity.
And you can't really open up somebody, do an invasive surgery simply based on this, right?
And now it's what we do. So if we have some concern for this patient and we are not sure if it can come from the stent or not, we send them to the catheterization lab to have this angiography procedure to know if there's something wrong in the heart or not. And most of the times, there's nothing wrong in the heart. So it could have been avoided. And with our technology, we can identify those patients that have these atypical symptoms and we don't know what to do with them, and say, hey, the stent is okay. And all major clinical trials have demonstrated that in this type of patients, doing an angiography or doing a PCI, what it's called, it's not helpful for reducing outcomes. So if we can ensure that the stent is good, we could avoid some of these procedures as well. So we have both the positive predictive value in these cases of identifying problems before symptoms in high-risk patients, and the negative predictive value in those patients that have symptoms but usually don't have a problem, and we could avoid some of these procedures and risks, because of course this invasive procedure angiography has risks for the patient, and it's not comfortable and it's expensive. So if we can avoid that, that's also good.
I can already see your technology has such unique approach to this problem, and of course I think there doesn't exist any alternative solution at the moment apart from just invasive surgery. So I don't see a challenge coming up, but I still like to ask. So I understand this device of Nimble basically can be placed into clinics or these hospitals where patients can just come in and get tested and just leave. So, but basically, have you faced any challenge, or what kind of feedback have you received from your target audiences about what your devices, and basically how is it going? I'm specifically talking from a perspective that how do we scale this and widespread this technology to as much places as we can?
Yeah. So the main feedback and what's been really interesting is understanding how each market acts quite independently. So for each specific country, you have a specific way to manage these patients now. And it's quite different between countries. For example, as I was saying, from Germany to Spain, which you say, okay, it's Europe, they should be quite similar. Then you start investigating and they treat patients almost the completely different ways. So in Spain, we try to optimize resources as much as possible. And we've always been like that. So if we can avoid the procedure, we try to avoid it. And then this negative predictive value of our technology has lots of strength, because what clinicians want to see is, do I need to do this test or not? If I don't need to do this procedure and I can avoid it, that's fantastic for me. So that's where they see the most value of our technology. But for example, in Germany or in the US, the clinicians and the hospitals get paid for each procedure that they do. So they don't want to lose revenue, and they don't want to hear that the technology can avoid procedures. So in the other way around, they focus on, okay, in these high-risk patients, I can identify these patients that have a problem before symptoms appear, and I can act and drive more procedures, but in those patients that really need it. So it's optimizing the patient management in the opposite ways, some optimizing it by reducing procedures and some optimizing it by identifying the most high-risk patients that we can help with a procedure. So it's having those balance and knowing what to focus. It's really important. And of course, for example, another type of feedback that we usually have is that, okay, you can check that the stent is okay or not, but maybe the problem is in another artery. And we cannot see that at this moment. We're working on it, but we cannot say anything about other arteries. And it's a fair, a fair concern. But the thing is that clinical trials have demonstrated that it doesn't matter if the problem is in the stent or in another artery. Getting a stable patient, stable with these atypical symptoms that we were talking about, to an angiography doesn't help and doesn't improve outcomes. We know that with clinical trials, but we still send them to this procedure because maybe it has a problem. And when this has a problem, there are also many studies that have demonstrated that one of the largest drivers of having a problem is stent complications. So if we can avoid that and know that that's not a problem, the chances of having a problem in a different artery that goes down very, very substantially. So that's one of the concerns that clinicians have with our technology, and we're working on that, of course, but we are very well tailored to the clinical guidelines and what the clinical studies have demonstrated to support these patients and clinicians. And the third, I would say, feedback that we receive mostly is where do we see the field of stents moving forward? And here, what our research has shows is that the field is more interested in what it's called biosorbable stents. So currently, a stent is for the rest of your life. You cannot take it out. So the longer that you have an implant in the body, the higher the probability that you have a problem at some point. And that's why our technology is so important right now. Stent manufacturers are working on stents that get absorbed into the body, so they last a few months or years instead of your whole life. In this sense, this was tested 7 years ago, and these stents had to be removed from the market because you have to imagine a stent in an artery getting dissolved and creating a paste, which ended up obstructing the artery. So the solution ended up becoming the problem. They took them out of the market. They are now redesigning them and creating new combinations of this type of stents. But what it's been clear is that if this gets to the market, this patient needs to have a very high DAPT therapy, which is dual antiplatelet therapy, which means the aggregants to avoid this thrombus from the stent itself getting absorbed. So in this sense, this therapy, this medical therapy, it's quite aggressive and it has downsides, specifically internal bleeding, because if you don't coagulate to not have thrombus, then the problem becomes that if a patient which is advanced stage falls and have an internal bleeding, not knowing and creating some problems. So it's a striking balance in this type of medication. And currently, we don't know when the stent has been absorbed or not. So it's standardized for every patient. We say 12 months of therapy and that's it. But some patients will have this stent reabsorbed previous to these 12 months, and some patients will have it after these 12 months. So you need to manage the medical therapy appropriately in those patients that has been reabsorbed before the 12 months. You can take out the medication and reduce the risks of bleeding. But in the patient that the stent is there still after 12 months, you need to continue the medication to avoid thrombotic events. So we have a technology that can monitor problems inside the stent. So knowing if the stent is there or not, it's quite easy. So we can help. Yeah, exactly. We can help in this future because it's still not on the market. But in this future, we even gain more importance in saying, hey, the stent is there, continue medication. The stent is not there, you can take it out. So we have this future-proof, let's say, technology as well.
This is nice, and actually I'm really enjoying this conversation because it's all of it is very new to me, and coming from an industry expert like you, it's really eye opening.
Yeah.
So, and again, what I know about medical industry is that even in medical devices space, one of the challenge a lot of startup faces regulatory
Mhm.
approvals, and so,
Yep.
and clinical trials and all. You've already touched upon success in clinical trials, but I'd like to know a
Mhm.
little bit about regulatory approvals, and maybe, for example, in US case you have to get FDA approved, and there are every country has their own rules of approval such medical devices. So can you take me through, if you have faced any challenge, or if you've already solved those challenges, or basically what kind of steps you have taken to maybe get these approvals or be more aligned with these regulations?
Yeah. So regulatory, it's always a challenge. We're classified as a class 2A in Europe and class 2 in the FDA in the US. So we need to demonstrate with clinical trials safety and efficacy of the technology. Of course, microwaves are non-invasive. So we have demonstrated over and over that it's safe, but we need to demonstrate it in clinical trials. And our approach is we have had this first in human trial finished, as I was saying, 11 patients. We have extended through these good results the pilot into 120 patients, but it's still a pilot study just to gather data and have heterogeneous population and find different situations for these patients. So patients with one stent, multiple stents, having another medical implant in the body, or being overweight or super skinny. So having a heterogeneous population, it's really important for us to improve our algorithms and our technology, and data is always good, of course. But the idea is to start our pivotal trial, get CMAC, in December. And so we are now preparing. First, we're covering to be certified by the ISO 13485, which is what regulates good practices. It's not mandatory, but it's a really good practice to have it. Currently ongoing on the process of being certified through this ISO, and generating all the documentation for the technical file. So how are we manufacturing the device? How do we create these reports? What's our tracking system? How can we put this information clearly to be then analyzed for a notified body and to get CE mark in the future? So we have been working a lot in regulation, and that's especially in Europe. And in the US, we have a meeting with FDA supervisors late April. And our idea is to present the project and ask for a breakthrough device designation, which means that we think our technology has the potential to save life and improve patients' life significantly. So it's not as much for the clinical trial in the US, but for then reimbursement purposes and creating your codes and CPT codes, or whatever we need to do afterwards. It helps a lot on having this program onboarding, because you can expedite a lot of this data ready to get CPT code reimbursement, and you can be much more dynamic conversations with FDA regulators instead of having to have the clinical trial data, send it over, they analyze it, we receive it back, improve the data. Maybe we need more population of a specific ethnicity or whatever it is, and we need to increase the clinical trial sample. Whatever it is, it's quite time consuming, but with a breakthrough designation, we can have these conversations much more dynamic. It's over email, quite rapidly, over weeks instead of months. So it can help a lot. And that's our approach in the US.
That's nice, and I wish you good luck for this,
Thank you.
because I also believe that this is actually a life saving technology. Some of my older members in my own family have stents implants, and again, the challenges that we have so far discussed, I've personally seen them facing these challenges and going to and
Yeah,
going
and
through
it's
regular
that they
checkups.
don't have a follow-up. They just go to the cardiologist. Are you feeling fine? Yeah, then we assume everything's fine and you can go home.
Yes.
Patients are concerned. They want to know how it's the implant going. Yeah.
Yeah, and actually, if sharing my personal experiences, so once, of course, it's very important to get checked, right, for patients, and they would like to regularly see that if they're doing okay or not, right? And when they go to the doctor and then they get checked and everything seems fine, but they still have to, pay them for the checkup, and these checkups
Yeah.
are again very time consuming, expensive. You have to take appointments, so there's always a I won't say disappointment. It's not
Yeah.
a bad thing, but they be like that. Okay, we went there, we spent so much time, we spent some money, and I mean, it's a good thing that everything is okay. But man, it took a lot of time to get to know this. I hope
Yeah.
everything was okay without checking it. But I can see the potential of your tech, what Nimble has made, and it will make life so much easier for these patients. And definitely, it's a life saving breakthrough. So
We
good luck
appreciate that.
uh, for the approvals. And so I'm almost at the end of my question line, but so my next question is related to the future for this device. And of course, I'll first ask a very sci-fi ambitious question, that do you see, and this was the question that came to my mind when we were talking, and basically, do you see this device becoming so easy and accessible that people can have it at their home, they can operate it themselves, and maybe it's as small as they just wearing like iron arc reactor, you just place it on your chest and it tells you if everything is okay. So do you see it like innovating to that level where it becomes so much accessible?
That's in fact our end goal. That's where we want to go. However, we have very high technological challenges to get there, because to generate the microwave in the frequency that we want, the quality that we want, we now use what is called the VNA, which is a vector network analyzer. These are very expensive units, and they're super large and heavy. So it's now impossible to have this, but we are working and thinking of how can we miniaturize this internally and have it inside the company. So in the end, we can have something, because one of our main goals for the patient is to empower them to know how the implant that they have in their body is doing. So the maximum expression of that is that they can check it at home whenever they want to feel safe and comfortable, etc. That would be fantastic. We have lots of challenges. That's the end goal, and we're talking maybe 10, 15 years into the future, we want to go there. But for us, the future looks more into diversification, because in the, let's say, the mid future, because what we have, it's a pipeline technology that in fact can be used for any metallic implant.
Yeah.
Or that's the rationale behind it. Of course, we need to test it and we need to do a lot of experiments afterwards. And we are now focused on cardiac stents, but other type of stents, it's the first, the logical application. So to check peripheral stents, cerebrovascular stents, pulmonary stents, renal stents, vesicular stents, whatever it is, that's the first logical application and what we want to test that, of course. Then valves that get calcified, prostheses that gets infected. We have sensors that gets encapsulated. We also have industrial applications, because we have a sensor that can tell you how a metallic piece is structurally. We can know, we can detect very small variations on that. So to automate quality control of manufacturing of metallic pieces, for example, stents. During stent manufacturing, now to check if a stent is well or not, the quality control, it's a destructive test, because you need to take the stent, put it into a microscope and analyze it, but then you can't use that stent anymore. So it's a batch approach. And with our technology, we don't need to touch the stent. It's completely automated. In milliseconds, we know if the stent is deviated or not from what this specific metallic piece needs to be. So we can automate quality control for metallic pieces. The mobile industry, for example, being one of them. So we have lots of applications, lots of things to do.
Yeah.
We're now laser focused. We're a team of 12, laser focused on cardiac stents. But the next step is to expand the indications, and in the future, of course, always thinking of how can we miniaturize this to get to patients at home.
Yes, definitely. And now that you mention, I can also see, not just in medical space, I imagine it could be used like anywhere where you need quality control, because this is using microwaves to monitor such minute structural integration of metallic parts. I think it doesn't have to be limited to medical industry only. There will be
exactly.
applications.
Exactly.
And so it was, I mean, actually, I'm at the end of the line of my question. All the questions are answered, but I still have just one, and this is coming from my personal curiosity. Oriol, basically, when I was researching about Nimble and I was also reading about you, I saw that you have such extensive academic background, a really strong medical experience, and this is your first company, right?
Yep.
And say, so, coming from really deep academic background, and you have so many papers published, you also have patents filed in your names. So you're like very strong suited scientifically. But entrepreneurship is something that you stepped into, right?
Mm-hmm.
And I'm sure, like any founders, I've talked to so many founders, you must also face this, that, okay, is this going to work? Is scaling this company will be possible? Or maybe what if this fails? These fears are always there, right? And but what I want to know is basically, how do you deal with them, and how do you keep going? And basically, what's your secret formula to
Yeah, so as you said, I'm a researcher through and through. I did my bachelor's in molecular biology. I did my master's in genetics and genomics. I did my PhD in cardiovascular medicine. I worked with Stanford and Harvard during my postdoc. and I always been in academia. But there's that point where you go to from hot topic to publication, hot topic to publication. You're changing constantly on what you're researching. And specifically me that I went into this biomedical field to try to find solutions for patients, that you end up losing yourself a little bit into, okay, I'm researching a lot and I'm publishing a lot, but how does this get to the patient? I'm not helping anyone directly. Of course, having knowledge and improving the knowledge base of the whole field, it's good. Research is very necessary. Basic research without a specific goal, it's very useful because you never know when this basic research can help you in the next frontier of technology. For example, MRA was born through a physicist trying to look into space dust and clouds to see beyond them. And then was a clinician saying, maybe I can use that to excite the molecules inside the body so I can arrange them and have an image. You never know when this comes from, right? But you sort of lose yourself in this sea of publications and new things constantly emerging from everywhere. And when we had this research line and this idea to develop the Nimble, you start as basic research, as we always did, but then you start getting to a point where you say, okay, I've validated this in mice. I have the first results in pigs, and it looks promising. I can know if the stent is okay in pigs. We're not talking about biology. We're not talking about biochemistry. This is physics. So if it works in pigs, it should be quite feasible to and direct translation to work in humans. So then there's this moment to say, maybe I need to invest much more of my time in this. This can have a real impact quite soon. Of course, medical devices and medicine in general, it's a lengthy process always. You see the end of the tunnel. You see this can get to the clinics. And once I had this realization, to me it was a no-brainer. I had to try to develop this. Of course, was my first experience. I didn't have any type of training, nor in finances, nor in regulatory or patents. I didn't have that. So I started teaching myself and going through all the accelerator programs that I could find and getting all the grants that I could find that had this, let's say, learning program so you can understand everything. And I really liked how everything integrated. And so I started motivating myself to see if I understand this, I can help better on putting this device into the market. And it's sort of a positive feedback where as more you know and understand on how to do things, the clearer you see the vision on how can you bring this into the market. Of course, you still need to think outside the box and be innovative in how can you apply specific things to specific topics. But I've always liked that side of innovation. How can two different people see different applications for the same technology or different development paths? And I really like that. But yeah, there's no secret. The secret is trying to stay motivated and understanding that these fears of if this doesn't go through, what happens? It's not that I fear that, because I think that the technology is very robust and we've demonstrated a lot now in humans and in pigs, and we have lots of data. And that to me was never a concern, because I think that in innovation, of course, you never know. But if you think that the end goal is worth it, you have to try it. It cannot work, but you have to try it. If it's worth it, yeah, to me, it was a no-brainer, as I said, because I don't fear that. Of course, I feel the pressure of having people working for me. And if I don't get enough funding for the company, yeah, that's what keeps me maybe at night, to have everything well checked. I've never managed a team of 12 like I did now. So all of that sort of people management and thinking on how to fund this the best way, because of course you can do it through public funding, you can do it through private funding, you can do it through loans. So having the best combination of good team, good funding, good development, and a clear path front, it's what drives me.
Yeah. I think what I got, most important thing I got out of this conversation is really believing in what you are doing is going to have a greater impact is what keeps you going. Because, and then, everything else falls into place if you really know that, okay, the whatever.
But it's important. But this is tricky, because you have to understand when the project stops making sense and not pushing it just because you started it. So if at some point you identify that this has no value, You have to identify that and be comfortable saying, okay, this doesn't make sense anymore.
Yeah,
So
yeah.
not pushing it just by itself,
The
but if
sunk
you're
cost fallacy, right? That what it says, like,
exactly,
yeah. So
exactly.
I understand totally. And with that, Oriol, that was the like my last question. And thank you so much for taking the time and taking me through this in such detail of what Nimble is doing. I really enjoyed this conversation.